Now, last year at San Antonio, we saw the results of the plasmaMATCH study. I think it's one of the largest studies that's actually looked at ctDNA in patients with metastatic breast cancer. It came from Nick Turner's group. It was an open label, multi-center, multi-cohort trial with ctDNA testing in over 1,000 patients. These patients, once they had their ctDNA and they had these different targets, they would then divide into different cohorts. If they had an ESR1 mutation, they had extended dose fulvestrant. If they had HER2 mutation, they were given a combination of neratinib and fulvestrant. If they had an AKT1 mutation, they were given capivasertib. And if they had an AKT, if they had an AKT, then they could go into an AKT basket type cohort in which they would get capivasertib alone rather than in combination with fulvestrant. And what they essentially showed was that if you had an ESR1 mutation and you used extended dose fulvestrant, there was an overall response rate of about 8.1%. If you had a HER2 mutation, you could give a combination of neratinib and fulvestrant, an overall response rate of 25% was attained. If you had an AKT1 mutation and gave a combination of these two agents, 25% response. And if you just use single agent capivasertib in the AKT basket cohort, again, about 10.5%. Again, these were very, very interesting results that came out. They also looked at the sensitivity between ctDNA versus paired tumor tissue sequencing, and the overall sensitivity was 93%. So very good results that came out of this, really suggesting that it was reasonable not to do tissue profiling and just to do those liquid biopsies over time to look at those acquired mutations.